It's my delight to introduce the upcoming last session today about the update of neonatology. Our chairman of this session, Dr. Niran Al-Naqib. Welcome, chairman of neonatology department, Al Adan Hospital. Also, Dr. Ahmed Sayed Isa, chairman of neonatology department, Al Jar Hospital. Welcome for both of them.
Good evening, everybody. Our neonatology session now will begin with Dr. Julian David Eason for a very interesting topic. It's about non-invasive ventilation strategy in neonate. Dr. Julian Eason is a chair in the Department of Neonatology in Corniche Hospital in Abu Dhabi. He was also a clinical director of Women's Service and lead neonatologist in 3 different UK institutions. He has a fellowship Canadian and UK in neonatology. He has special interest in neonatology nutrition and neonatal transport and ventilation, and certified in neonatal aviation medicine and transport. He is also a representative of British Association of Prenatal Medicine, and welcome to Dr. Julian.
Thank you very much indeed. Assalamu alaikum. And thank you very much indeed for the organising committee for inviting me to my first visit to Kuwait. So I'm going to talk to you about non-invasive ventilation, and I think it does certainly have some aspects related to pediatrics in some of the methods that I'll be talking about. I'm from the Corniche Hospital in Abu Dhabi. It's a 64-bedded NICU with about 1,000 babies admitted a year. It's a high-risk obstetric fetal medicine referral centre, with most of the UAE referring to the Corniche for that high-risk type of infant. So intensive care is very exciting and very interesting, and a lot of us go into it because it's very high tech. However, the babies I prefer to look after usually look like that, because this has been seen more and more commonly in neonatal intensive cares over the recent years. I think really the history of respiratory distress syndrome and its treatment, really we can go back to the 70s. We can probably go back further, but I think in 71 with Avery's paper on the use of Cpap in infants has seen a slow but steady progression. And in fact, we've almost gone back to the 70s by the amount of Cpap that we're currently using. Although antenatal steroids were shown to be effective in 72. We didn't really put them to good use until the 90s. We had surfactants coming in the 80s. We were very, very popularly ventilating virtually every baby with SIMV and high frequency in the 90s. And then came the CPAP revolution again with non-invasive techniques, micro-insure techniques for surfactants, so we could keep babies on CPAP. And I'll also talk about high-flow nasal cannula. So I think most of us know one of the reasons and a lot of the things that we talk about as to why it is so good is this survey in 1987 by Avery looking at 8 level 3 units in the USA, and this one unit, unit number 3, had a remarkably low level of bronchopulmonary dysplasia or chronic lung disease. Now I know that has many definitions, and the definitions have changed over the years, but assuming they were all using the same one, what was different about this unit? Well, they were very big advocates of CPAP. You could be a bit of a cynic in saying that if you have a baby on CPAP and it's in air, the baby doesn't have chronic lung disease, so it is open to interpretation. But essentially, this did show something quite different to a lot of the other units, and therefore it was taken very seriously. So what's wrong with ventilation? Well, I think to be fair, although I'm an intensivist, I don't really like it. Ventilation causes a lot of damage to our babies, let alone the volley trauma and the rear trauma, the electric trauma, whichever trauma you want to say, the ventilator certainly causes damage. It increases infection, it causes problems if we don't ventilate correctly. And if I was to be a little bit rude about a lot of doctors, I often see a lot of doctors not really understanding how to ventilate, which mode to start, how to wean. It's incredibly complex nowadays, the types of ventilation that we have to choose from, and we really do get quite confused as to what a baby baby wants. So I think the options are a little bit confusing, and I think it can be quite damaging. Now, PEEP is incredibly effective. I can give you a long list here of why PEEP is so good, particularly conserving surfactants, improving oxygenation, and reducing apnea. And PEEP, really, when I was training back in the 80s, wasn't really talked about a great deal. I was using PEEPs of 2 and 3 on a ventilator, whereas now we now see it at 4, 5, 6, and certainly we're using very high PEEPs now, over 10 in certain cases. So PEEP is effective, and I think it's being used more and more and being understood a lot more as the way we look after our infants. Now, why do we non-invasively ventilate? Well, if you look at this meta-analysis from the British Medical Journal of putting all the studies together, you can see on the left of this plot that the vast majority of the studies show that nasal Cpap is favored over intubation when it comes to death or BPD itself. Now, these aren't dramatically statistically significant, but every single one does show a trend to improvement for non-invasive ventilation. And therefore, that is why it's been taken up a great deal more. Now, there's many types of Cpap devices or the way PEEP can be delivered. So we have nasal Cpap, we have Cpap, we have assisted Cpap, nasal intermittent positive pressure ventilation. We have the high-flow nasal cannulas developing PEEP. And you can also now, people are now advocating using the oscillator through nasal prongs and calling that oscillating Cpap. So there are many, many ways that we can deliver this. And what's very interesting is if you look at the studies, many, many studies comparing the different types of non-invasive ventilation, they are all very, very similar. There's not a great deal of difference between Cpap. In fact, Cpap and Cpap, almost no difference at all, although people will have their preference when they're setting their infants up. High-flow nasal cannula and Cpap, very, very similar indeed. We'll talk a bit more about that later. And so people are comparing types of Cpap to see which is best. And at the moment, apart from NIPPV, which has a little extra that I'll talk to you in a second, they're all very, very similar, whichever way you administer Cpap, as long as you administer it correctly. Now, the NIPPV does appear, that's the nasal intermittent positive pressure ventilation simply through a nasal tube, not intubated, does show that if you take a baby off a ventilator and use NIPPV, it is a little bit more successful than putting a baby simply onto Cpap. So there is some evidence that synchronized NIPPV actually is a little bit more favorable when it comes to extubation in itself. But otherwise, most types of Cpap are pretty similar. And we know from these studies that, that our infants with RDS, we no longer have to intubate them and give them surfactant at birth. Okay? Prophylactic surfactant is now not recommended at all. Rescue surfactant is what we need to do. In other words, you need to assess whether your baby really needs intubation and really needs surfactant. You don't need to intubate your baby to give surfactant just because you want to give surfactant. PEEP is sufficient. The babies do just as well. Every single one of these studies showed there was no difference to the babies who were simply given PEEP as opposed to intubation and surfactant. You do not have to give surfactant just because you want to. You give surfactant because you need to, and therefore that's a rescue mode, quite different. So this study in 2014 looked at non-invasive positive pressure ventilation or CMV for neonatal continuous positive airway pressure failure. In other words, you have a baby on Cpap and it fails. What can you do about it? Now, we all have various failure criteria which we can talk about, but if you put you either ventilate a baby or put a baby on nasal intermittent positive pressure ventilation, this study that showed that 3/4 of those infants that failed on Cpap would not need to be intubated. In other words, they could stay unintubated on NIPPV. And so NIPPV is gaining momentum as a good way of looking after these babies and ventilating them non-invasively. Now, there are many, many types of Cpap generators. I'm not here to recommend any one at all. I have no disclosures at all to make. I don't favor anything because essentially, if you can generate PEEP, PEEP works. And it's up to you and what you have and what your comfort zone is for using your type of generator. Whether you use ones that tell you whether you have a fluidic flip, whether the baby breathes in or out, or whether you're simply using simple tubing. Likewise, the masks and the cannulae are many and varied. And we all have different suppliers and we all have different ones sent to us. There isn't one that I can tell you is superior to another. Each unit will have its one that the nurses are most comfortable with, the doctors are most used to, but all of those types of devices work. There isn't one that you can say is better than the other, or there haven't been the trials or studies to show, to demonstrate that. One thing I suppose that's more recently, and I think certainly used in pediatrics for the broncholytics, is the high-flow nasal cannula. I had the dubious honor of importing the very first old type one, the 2000i, into the south of England in the early 2000s. And I have to admit I've been fairly sold on this ever since. This is this high-flow system is very, very simple. From my point of view, it has one button. That's very non-confusing, very simple for doctors and nurses to use. And it simply delivers a flow of 1 to 8 liters. It has a temperature and it has an FiO2. And you can use this as a respiratory support because it also generates PEEP. We'll talk about how in a second. But it's more comfortable, it's easy to maintain, and I can guarantee you that when you see a baby on this as opposed to Cpap, the nurses and the parents certainly are much happier with this. Some of you may know about the Optiflow device. The Optiflow device is not the same as Vapotherm. It is quite different. It has a different humidity delivery. It doesn't deliver 100% to the baby like the Vapotherm. And if you use the premature size catheter, it sometimes struggles to deliver more than 4 liters with the tiny catheter. So it's not identical to the Vapotherm. And Optiflow and Vapotherm, although they are high-flow delivery devices, if you want a very high flow in an extremely premature baby, this device struggles because it has a blow-off valve at 40 centimeters, and the Vapotherm has a blow-off valve at 200 centimeters. So you can generate a lot more flow through the Vapotherm. But these are very popular, very cheap, very easy to use, and will work in most infants. So, what are the arguments we hear? We hear that the main drawback of using high flow, Julian, is that we can't measure the pressure. On Cpap, I can dial in 5 centimeters, and that's what I get. And with a high flow system, I can't. I just dial in the flow rate, and that's not good enough because I don't know what I'm giving the baby. So my question is, when you dial in 5 centimeters of Cpap on a Cpap device, do you really think you're getting 5 centimeters of water delivered to the baby? And so the answer is there's been some studies on that which show that that Cpap is not necessarily giving you what you want. So the arguments for using high flow are those before you there. It's effective, it's easy, people like it, it's very simple. And Dysart has done some studies trying to compare high flow and Cpap to try and convince people that actually they're not that different, although you're dialing in different parameters. Because he was looking at the mechanisms of action of high flow therapy. And high flow certainly washes out the nasopharyngeal dead space. It certainly reduces the inspiratory resistance. We know it improves pulmonary compliance. It's a lovely warm humidified gas, reducing the metabolic work, and gives you a pressure. Admittedly, gives you a pressure that you can't measure. But very interestingly, all that happens with Cpap as well. And if you look at the mechanisms and you look at the flow when a baby is put onto Cpap and high flow, it's incredibly similar. What's interesting is that when you think you're delivering 5 centimeters of water on a Cpap device, and your flow is fixed, if the green line is 5, when a baby closes its mouth, it might be getting 7 or 8 centimeters, and when it opens its mouth, it might be getting 2 or 3 centimeters. So even though you've dialed in 5 centimeters as Cpap, it's very variable what the baby gives, and you don't actually know the pressure you're giving, but it seems to work. And of course, with high flow, you're dialing in a flow, and although you don't know what pressure you're giving, it also has a similar outcome, because the blood gases are the same, and the baby recovers in the same sort of way. And so, in reality, when you look at the Cpap pressures, how vastly they differ with the baby, and you're not really giving what you think, it's actually very, 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 very simple that the Cpap and high flow, their mechanisms are actually pretty similar, apart from one sealing the nose and having a mouth open, and one not only partially occluding the nasal passages. So because high flow is easier and has less nasal trauma, it's helped me be convinced that it is equal to the Cpap that I'm giving my other babies, and I think there'll be more and more studies that have come through that shows that it's very effective. So the overall outcomes from all the randomized control trials that I can find to date, looking at Cpap versing high flow nasal cannula, is that the one thing that is stated in every single paper is that the nasal trauma is significantly reduced. Now, I haven't seen a great deal of nasal trauma, but we know it does happen with Cpap. We know these tiny babies can be very badly damaged, and this doesn't happen with high flow nasal cannula. The extubation failure rates for Cpap and high flow in the studies that have been done to date are very, very similar. There is no statistical difference between them, and there's no difference in mortality and morbidity. And I think that's pretty good evidence. And this latest paper in 2014 was looking at...
Excuse me, Dr. Eason,
yes.
You have 5 minutes.
5 minutes, oh, that's lovely. Thank you very much. Sorry, so essentially, high flow is fine. I have no problem saying that it is equal to Cpap. If we continue to look at the non-invasive papers that are coming through, there was a Cochrane database in 2014, which once again was saying how effective NIPPV is. So NIPPV, as much as I might be converted to high flow, appears to be very effective, and if it's synchronized with the infant, there doesn't appear to be any the synchronization doesn't actually have to occur with NIPPV. So although initially people wanted these breaths to be synchronized with the baby, a lot of the papers are showing that actually that makes no difference at all. So the question comes down to really, if we're happy using these Cpap and high flow devices, when do we ventilate the baby? Well, ventilating a baby, I think, can be quite subjective, although most of us will have the same pretty much ideas. A baby is depressed, requires more than 40% oxygen. You really want to be able to give that surfactant, and of course we have insure techniques where we can give surfactant and come back out onto Cpap again or high flow. Frequent apnea, severe distress. Some people like to make sure they ventilate all their tiny babies. But there's no doubt there's a failure rate of Cpap and high flow the lower the gestation of an infant. About a 50% failure rate we have in about 25, 26 weekers. So it isn't perfect. And of course then there's your own clinical judgment or clinical assuredness about what you can do. So all I wanted to say today really is that there are actually very few differences between nasal Cpap, high flow, and NIPPV, although post-extubation, NIPPV just seems to have the edge of keeping the baby off the ventilator. High flow is easier for nurses and mothers and causes less nasal trauma. As I said, NIPPV is perhaps more promising. And I think, from my point of view, you should use which suits you, use what you're using, and use your PEEP wisely, because if it is used wisely, we don't necessarily have to ventilate as many babies as we used to. The biggest problem I have with all this is that very few of these studies, in fact, none of them show you any real statistical significance that they decrease chronic lung disease. And that is probably what we all want to do. Now, there are those who think chronic lung disease is not necessarily the right measure for looking at these babies. There are some very interesting papers coming out showing that the chronic lung disease is not a good marker of long-term lung function. And in fact, there are some papers coming out showing the type of ventilation that these infants got is far more related to their long-term outcome than necessarily their categorization of chronic lung disease. So thanks very much, and hope all our babies can look like this very soon.
Now we are opening for questions to Dr. Eason.
Thank you so much. Really amazing. It's which suits you better. This is, I think, the best word. I have only one question from your clinical experience, not from the slides, not from the research. You said you use the surfactant when it needs to be used. Do you mean less than 26, 27? You don't use, experience-wise I'm talking, not you don't use it at all unless he needs the baby, if he's stable on Cpap?
So if we're talking about personal practice, yes, correct. We will not give surfactant to any infant unless it requires. In other words, if the baby's apneic and requires ventilation, if it's a 26-weeker, I can put on PEEP and stays on PEEP and comes back to the NICU on PEEP. There's no surfactant given to that infant at all. We don't routinely give surfactant, and there are many papers now saying prophylaxis is out, it is unnecessary. So no, I would not give surfactant. I would wait, and we can of course talk about even some of those infants who come back and we think are going to be temporarily ventilated. In other words, they've just got a tube for stability and they're ventilating in air. We still wouldn't give them surfactant, no. Although, of course, the surfactants are different. I don't know which one you use here, but we've introduced Curasurf, which, of course, is a much, much smaller volume and my biased opinion, far better than Savanta. Savanta is 4 mils per kilo, unfortunately, and Curasurf is 2.5. And that is, and there are some studies that show it perhaps has an edge on survival, so that's why we use it.
Regarding the nasal Cpap, the mode of delivery, like what is the place of bubble Cpap?
Yes, the bubble CPAP's fine, no different at all. It's a nice, easy, simple mechanism to use, much, much cheaper than buying a driver. Very happy with bubble CPAP. But don't think bubble CPAP is better than any other CPAP, or any other CPAP is better than bubble. It's the same.
So there's no difference in load given and the bubble Cpap?
No study shows it's superior, but it's not very easy to use. And can be used in obviously, in poor economic areas, and it's fantastic because it's just so simple. So bubble CPAP I'm a big fan of in low resource countries.
So it's more of a theory that bubble Cpap, because of the oscillation, is for better recruitment and
It's a nice theory, but it's not proven.
Thank you very much, Dr. Eason, for a fantastic presentation.